strategy has been to communicate to the public, to patients, to the you, choose wisely. When you go to the doctor for a regular physical, don't get an EKG. If they suggest an EKG, say no, I don't need it, I don't want it. I know you'll make 50 bucks more by doing it, but I don't need that, because Safeway is going to have to pay for it if you do it. And it doesn't do me any good. So there's a list of these kinds of things. Imaging studies in patients with low back pain is not indicated. It's not valuable. So now Consumer Reports, Consumers Union, is developing all the collateral material for consumers, and employers are going to start pushing this out to their workforce. AARP just published a special issue of their magazine with this stuff in it. So the question is, how do you get consumers and doctors to talk to each other about what's appropriate? And what technology, these are all technologies, which technologies should you as a consumer, as a patient, be seeking or avoiding? Last thing I'll just mention is technology assessment. This is a group of employers in New England who got together and formed their own council to look at each new technology and decide whether to pay for it together. So there's a lot more activism on the part of employers now around this set of issues. Very last thing is the policy agenda. I did mention policy work, and this is the place we might want to talk about health IT. We do a lot of work in Washington on national health policy, on all these things here, all of which are somehow meant to address appropriate use of new technology. So this is just sort of signaling to you that these employers I started talking about, this is what they are worried about. How do we create an environment where new technologies that are valuable and improve health outcomes get adopted, and those that add to cost and don't improve outcomes don't get adopted? And how do we do that? These are all capitalists. They want to do that in the marketplace. They don't want the government to say, thou shall not use this technology. They want to create an environment that rewards appropriate, effective care and doesn't reward unnecessary, expensive care. So that's what we're doing. So my last slide is messages to you guys. Implications for developers. First of all, understand what pressures your providers, if they are your market, are under. They are under pressure to improve efficiency. They're under pressure to document outcomes of what they're doing. They're under pressure to increase coordination, including across settings and across time. And they're under pressure to be accountable for what's appropriate in the care they provide. If you're selling to consumers, understand the pressures on them. They are feeling increasing cost sharing pressure. If they work for Safeway or Intel or Cisco, they are paying more of the bill themselves. So they're more cost sensitive than they were 5 years ago. They want and they're getting more information on prices and quality. Companies like Castlight are being supported to deliver information, to push information to the consumer. And most of them are facing more, frankly, responsibility, either good or bad, for the decisions they make. There is a lot of interest in patient engagement and autonomy, treating all of us as adults capable of making decisions about our health care and which treatments and services we're going to use. So that's an opportunity, I think, for many of you who are going to be selling directly to the public. And then lastly, as I mentioned before, innovate. Innovate is good. New care models, new care processes is good, but you're going to get a wariness or a skepticism from at least the large employers that a new gadget is necessarily good, unless it fits into a care process which seems to make sense and ultimately lead to more efficiencies. I think I'm done. Thank you all. Take a few minutes. 5 minutes, all right.
So, in your crystal ball, since you look at large employers, and these are firms that can afford just about anything you want in general, do they have a motivation? There's a switch.
There we go. Goodness. Sorry about that. How's that? Is that better? Okay. Part of the thing, you work with large employers, and I've actually worked with some of those large employers as a marketing consultant. But the issue is that it would seem, when I've been sitting in the executive suites, they're trying to find ways to cut costs. It would seem to me that a single payer model actually benefits large employers. Have they figured that out yet?
I think they understand that. It goes so deeply against their culture that they aren't quite there. But I have, in our private closed-door meetings, the last 2 years, I would say they see that as a 10-year roadmap that is plausible. It's not their desired outcome. They would rather have a competitive market. They think that works better. That's what they believe. But they are no longer, I think 10 years ago they thought single payer was unacceptable. Now they think it may be the right answer.
I like that slide, the Safeway slide of the cost of, what was it, colonoscopy. And I'm thinking, since most of those employees are paying a copay, if the company said to them, if you get this colonoscopy at a price below X, we'll pay part of your copay. If you get it below Y, we'll pay all of it. And if you get it below Z, we'll pay all of it and give you a bonus. And that was combined with a law like the law for gas stations that have to post their prices, thank you, that these places have to post their prices, which of course they'll scream about, but it's doable. I mean, if the Chief Justice of the Supreme Court can say that mandated insurance is legal, then we can certainly post prices. Do you think that combination is the kind of thing that would reduce the costs and give the competitiveness of the marketplace meaningfulness when the consumer actually cares about the price?
You have an opportunity at Safeway, because that's what they did. They went to this line, and they went to $1,500, which is here, and they drew a line. And they said, we will pay, anywhere you want to go, we'll pay the first $1,500. If you want to go here, you can go. You're going to pay $2,200 out of your pocket if you go there. So publishing the prices was critical to that strategy, so that people would know before they made the decision that that's the implication. Safeway's strategy has actually been to take what you described.
So Safeway had to publish those prices?
Yeah, that's what they hired Castlight to do, essentially.
And it took probably quite a bit of effort for Safeway to put that together, and that's just for one procedure.
Right, they've expanded that. They have gone after the commodity services like labs, imaging, X-ray, colonoscopy, and that's where they've done a reference pricing there. CalPERS, the state employee program, did the flip of that. They went after the very high-cost services like orthopedic surgery, spine surgery, and they set a reference price, in this case of $30,000 for total hip and total knee, and said if you want to go to the $80,000 hospital, you can, but you're going to pay $50,000. Now obviously that only works where the consumer is properly informed in advance.
Exactly,
And
that's
elective situation.
That's the issue of having the prices posted like the gas station.
Right. Yeah.
Did Safeway go the next step and extrapolate that data to look at outcomes based on each of those individual places, and then also take into account how many biopsies were done for which polyps and things like that?
I don't think they did, at least not adequately. One of the failures of this model is that it makes an assumption that today we have no discrimination based on quality among them, so it's not any worse to draw this price line. Personally, I think they should associate a quality standard with the introduction of a price threshold, because otherwise they'll be accused, rightly or wrongly, of skimping, and if somebody goes to one of these places because it was cheaper and has a bad outcome, the company will be blamed for having directed them to the lower priced place. So I think it should be a corollary of this model to capture quality data, and I don't think they've done it adequately.
So he's next. He's next.
I'm sorry.
Sorry. So a quick question. Using this slide reference to another slide you have about how hospital or doctors are being paid for the total hip replacement. You're saying over a 20 years period their payment has been very stable, and the cost driving that up is actually technology. So have they done a study on this particular slide? Is the cost differences because they use different technology, or is actually the labor cost of those is varies?
Well, actually, it's hard to see, I'm sure, in the back, but this orange color is room and supplies, which is not the technology input to this. These people are charging hotel fees, basically. So on this particular example. But your point's well taken. One needs to drill down on any of these and make that assessment.
Monte Carlo hotel fees.
I just wanted to really close on that also. Then it seems to
Point it away from the speaker.
I'll point it away from the speakers. If you look on the list, number 5 is the city is located in Stockton, California, which is notorious today for having been both a county seat and a city to file bankruptcy. And it seems like there may be some value also in considering what behavior changes in the consumer base due to the net operations of these facilities. And I guess I'm really asking a question about how when you are a market maker, do you deal with the issue of sustainability? Because the pricing models that are being used there may not be appropriate on scale.
Right.
And that was sort of a...
Yeah, I think this is a blunt instrument and doesn't address a lot of the issues you all can raise about the weaknesses and risks of this approach. I wanted to share it with you partly to say what the employer's fed-upness is starting to look like, that they're going to start setting these I can't take it anymore levels, and just saying affordable means $1,500
for this category.
for this particular service. One of the things in terms of reputational credibility, when CalPERS did their total knee and total hip strategy, they made sure they picked a number that included Cedars-Sinai, UCSF, and Stanford. So they didn't want anyone to say, well, Stanford, I can't go to Stanford anymore. No, you can, it's under the line. So they bumped the line up to cover the reputational issue.
Okay,
These
so
are-
then
these
pick the
are-
next person.
Oh, I'm sorry, go ahead.
How do your employers feel about the favorable tax treatment for benefits?
No, we're about to talk about it, we haven't yet. I don't think it's going to be a big issue for them. That is, a change in the tax exclusion would be considered palatable. But they don't think it's a cost saver. That is, there's some argument that changes in the tax treatment would lead to a downward pressure on prices as a whole. And I think instead it's really being looked at as a revenue generator for the government. And until that's clarified a little bit, I think the employers won't know where they come out on it.
This example is Safeway, but there are lots of smaller organizations out there that are not self-funded, and they're purchasing fully loaded or fully insured plans through payers. Have you seen any of these types of programs that the payers are actually doing, wherein they are combining both quality and cost thresholds?
Yeah.
And which ones are they?
Well, the term of art in this is called tiered networks, and essentially they're trying to identify groups of physicians and hospitals who do deliver higher quality outcomes with less expense incurred. And then they give them a gold star, and then the trick is to either have a narrow network where you kick out the providers who don't meet that criterion, or more often now, you say to the employee, you know, we're going to waive your copay if you go to the good providers, and we're going to make you pay a lot more if you go to the bad providers. So that's a tiered network, like a formulary only for providers instead of for drugs. The question is, there probably isn't, so United Healthcare has done that, Aetna has done that, for example, Blue Shield has done that. The problem is it's not convincing that the providers they're choosing are really superior because the quality of the data they're using to make those judgments. So one could be suspicious that they really fall back on cost saving.
Are they using claim data versus
Yes.
actual clinical
Yeah,
data?
they're using claims data.
Okay, we have to kind of cut it short
Okay.
here. So if you have additional questions for him, I'm sure he'll stick
Happy to,
around.
right.
So let's give a big round of applause. Okay, at this point, we're going to take a short break. And so what are we going to say, 10 minutes?